Okay, we're going to go ahead with our, hopefully it's the last one. It may have to be divided in two though, but hypertension in pregnancy. Hypertensive disorders, basically, we know there's going to be uteroplacental insufficiency, responsible for a lot of premature births. Maternal deaths worldwide, 10 to 15% can be attributed to preeclampsia and eclampsia, which is part of this whole arena of hypertension. And preeclampsia accounts for more than 50,000 maternal deaths per year. So, very, very serious condition. And we're going to go here and stay here for a while because it's all going to make sense just if you follow the arrows and what I'm going to tell you. So, basically, hypertensive disease in pregnancy is divided into clinical subsets, as you can see. Is it just hypertension? Is it chronic? Did they come in with a heart issue to begin with? Superimposed PIH can lead to preeclampsia. If we don't stop here, we can go to eclampsia, and then we can end up in HELLP syndrome. But in looking at the arrows, we can have just hypertension or chronic hypertension. This would be hypertension, regular hypertension with pregnancy. This is chronic, can actually lead to HELLP without going through these steps. So let's look at the definitions of all of them. It'll make more sense to you. So again, hypertensive disease in pregnancy is divided into clinical subsets of the disease based on end organ effects and progresses along a continuum from mild gestational hypertension, a mild or severe preeclampsia, eclampsia, and once we go into hemolysis, we're ending up into HELLP syndrome. And HELLP syndrome means hemolysis, it's the breakdown of red cells. EL goes together, elevated liver enzymes, so now we have the liver involved, and low platelets. So very, very big chance that they can bleed. This is very serious. Most of those patients end up in ICU that are in the HELLP arena. All right, so let's back it up. Let's just go back to pregnancy-induced hypertension or gestational hypertension. We're just going to say they're hypertensive. So this usually begins after the 20th week of pregnancy. The elevated blood pressure needs to be 140 or 90 or greater. 140 over 90, 140 over 90 or greater. The systolic is an increase of 30 mmHgs or a diastolic increase of 15 HHMGs from pre-pregnancy baseline. So what that means is if they usually run around 100, we'll say they run around 100 over 70. If now they're 130 over 85, we're going to watch them. You see the baseline, how I added that. If they usually run 100 over 70, now my definition was the systolic increase of 30 mmHgs. So now they went from 100 to 130 systolic. Diastolic was around 100 over 70. 70 went up 15 mmHgs. So now they went from 100 to 130, the 30, and they went from 70 to 85. We're going to watch them. They're becoming hypertensive in pregnancy. So again, gestational hypertension begins after the 20th week of pregnancy, elevated blood pressure of 140 over greater, 140 over 90 or greater, the systolic increase of 30 mmHgs, or a diastolic increase of 15 from the pre-pregnancy baseline. So I actually gave you an example where they both went up. What if it went from 100 over 70 to 130 over 70? We would still watch them. It doesn't have to be both. Or 100 over 70 and they went to 100 over 85. That's even worse because you've got less of a pulse deficit, a pulse pressure deficit on that one. But you see 100 over 85, they went up diastolic 15 points. So with this one, along with that, there is no proteinuria or edema, and the client's blood pressure returns to normal by 6 weeks postpartum. So we're going to say they had pregnancy-induced hypertension only. That's it. So now we're going to move on to, and that's what that is, this one, PIH. Now we're going to move on to our preeclampsia, and we're going to divide preeclampsia into mild and severe. So mild preeclampsia is gestational hypertension. So that's what this is. We've already got the gestational hypertension. So they've got a raised blood pressure, but no protein yet. But now the reason they've moved out of this box is they not only have elevated blood pressure of the parameters I just gave you, but now they have 1 to 2 plus proteinuria and a weight gain of more than 4.4 pounds a week in the second and third trimester. So they're gaining weight, which means they're probably holding on to fluid and edema, and they've got 1 to 2 plus spillage of protein in the urine. Mild edema will begin to appear in the upper extremities and the face. Remember how I've said all along, it's okay to have ankle edema. It makes sense because of that big gravid uterus sitting on our large vessels, returning the fluid and blood to the heart. But whenever it's centralized, if it's in the arms, hands, face, or neck, that is a problem. So with mild preeclampsia, again, they've got gestational hypertension, so we've got that blood pressure elevation. We've added now 1 to 2 plus proteinuria, a weight gain of 4.4 pounds a week in the second and third trimester, and now we're seeing mild edema in the upper extremities and face. And so the second part of that, severe preeclampsia, how are we moving into that? That consists of a blood pressure that is now at least 160 over 100, and I've seen it way higher than that or greater. The protein spillage is 3 to 4 plus, so we've got kidney involvement now that's getting not good, getting bad. Oliguria, low level of urine output. Elevated serum creatinine greater than 1.2. Remember, creatinine is that little tiny margin. It's under 1. Cerebral or visual disturbances. They can have hyperreflexia, pulmonary or cardiac involvement, extensive peripheral edema. We have edema everywhere, central and peripheral. Hepatic dysfunction, and sometimes they have epigastric and right upper quadrant pain, which is signaling we're going into HELP because of the liver involvement, elevated liver enzymes. So they can have headaches, double vision, blurred vision, flashing lights in the eyes. So I'm going to read or talk to you about severe eclampsia again. Consists of blood pressure that is 160 over 100 or greater, proteinuria that's 3 to 4 plus, oliguria, elevated serum creatinine greater than 1.2 milligrams per DL, cerebral and visual disturbances, headaches, double vision, blurred vision, flashing lights in eyes, hyperreflexia. The reflexes are, you're getting very hyper responses to that knee and the elbow when you tap it. Pulmonary or cardiac involvement, extensive peripheral edema, hepatic dysfunction, which means we're going to have elevated liver enzymes, epigastric and right upper quadrant pain. That's where the liver is starting to get involved, and thrombocytopenia. And so eclampsia is the easiest one. You don't have all these breakdowns of numbers, whether it's mild or severe, how high is that blood pressure and PIH. With eclampsia, it's severe preeclampsia and with seizures or coma. So the whole goal here is with a preeclamptic patient, we want to prevent this seizure. We already know from our patho days that seizure is going to have, dire consequences for the baby with lack of oxygen to the mom. If there's 60% lack of oxygen in the mom's brain, what is the baby's brain going to get? All right, so that's basically, eclampsia is the easiest one they're seizing. Eclampsia, though, make a note of this, is usually preceded by a severe headache, severe epigastric pain, hyperreflexia, and usually that. Sometimes it's just double vision and a headache is what I've seen. So what is HELP syndrome? HELP is a variant of gestational hypertension in which hematologic conditions coexist. And so what we have hematologically, hemolysis, we know, is the breakdown, lysis, of red cells. We've got elevated liver enzymes, and we've got low platelets. So 10 to 20% of women who have preeclampsia with severe features will develop this. So basically, it's when they go into the severe preeclampsia for the most part. Let's see. Hemolysis can result in jaundice and anemia. The elevated liver enzymes resulting in elevated, it's usually the ALT and the AST, which is ALT, alanine aminotransferase, or aspartate transaminase, which is AST. So I'll say that again. ALT is alanine aminotransferase, and AST is aspartate transaminase. They have epigastric pain with elevated liver enzymes, and it's over in the right upper. And so it's really letting you know, the uterus isn't up there. That's the liver. And they have nausea and vomiting also. And the low platelets they're screaming at you. They are usually less than 100,000. Now we know anybody that's around 100,000, because normal platelets are 150 to 450 or 400, depending on the hospital. We know 100 is a critical value. So these people are in rough shape. And with platelets that low, can you imagine the delivery of bleeding to death? So it's this whole thing is a little crazy. The chronic hypertension I didn't go into, that is somebody that comes in with a lot of times a congenital heart, and the statistics are not high that they would come in. They already have hypertension. If they already have hypertension, 10 to 1, they're going to go into one of these situations, but not all the time. So again, chronic hypertension is elevated blood pressure present before pregnancy or diagnosed before the 20th week of gestation. That's chronic, meaning that maybe they didn't even know they were hypertensive, and they come in. If it's before the 20th week, they're going to do some studies on them and possibly family members and find out that, yes, they have chronic hypertension. And again, women with chronic hypertension can definitely acquire preeclampsia and eclampsia and may be very difficult to diagnose. Let's see. AST, just to give you some normals, and I'm not going to ask you normals. I will just tell you they're elevated on a test question. But a normal AST is 10 to 40, and a normal ALT is 7 to 56. And these numbers are usually in the hundreds or thousands with this condition. Okay. So that's PIH in a nutshell. The vascular pathological changes with preeclampsia. I mean, this is big. The pathology is going on. We have angiotensin II resistance. What does angiotensin do? Do you remember? It constricts vessels. It's good for shock, but it also elevates the blood pressure. We've got a sensitivity to angiotensin II, and so it's an increase in sensitivity. This is a diminished. I should have put an arrow here. There's an arrow that goes down, and I think it is in your PowerPoint. Diminished angio-2 resistance. So we've got all this angiotensin II, again, pathology with this condition, and increased sensitivity to it. We've got diminished vasodilators. We need the vasodilators. We've got all this constriction going on. That's why we have hypertension. And we've got increased peripheral vascular resistance. Remember, that's always the definition of hypertension. So we've got vasospasms, we've got constriction, and we've got diminished organ perfusion. It's a progressive disorder, and they don't always, but this is all theoretically because this only happens with pregnancy. It says that the placenta is probably the root cause because it's not usually there. Spinal arteries in the uterus normally become larger and thicker to handle the increased blood volume. And this is vascular remodeling, folks, just like we see in hypertension. It does not occur or only partially develops in women with preeclampsia. So again, even though it occurs, that's how we know this only happens in pregnancy only, because it doesn't stay that way. Once the baby's delivered, it's gone. All right, I hate to tell you this, but I'm done with my time, so we have to stop, and I will put the next one up.